Good morning and welcome to the press conference from the 56th Annual Society of Thoracic Surgical Meeting in New Orleans. I'm Robin Cohen from the Keck USC School of Medicine. Our next presentation is entitled Multi-Institutional Phase II Clinical Trial of Intraoperative Molecular Imaging of Non-Small Cell Lung Cancer, to be presented by Dr. Sarkaria from the University of Pittsburgh Medical Center. Dr. Sarkaria.
Thank you. Thank you very much for the privilege of presenting this. Get started. This is a disclosure slide. There are no disclosures from any of the investigators on a personal level. The trial was funded by industry through individual grants to the institutions. There are over 200,000 cases of new lung cancers in the United States every year. Surgery remains the gold standard of treatment for early-stage lung cancer. With increasing screening, better CT scans, we are seeing these nodules, these cancers at much earlier stages, and the numbers of early-stage lung cancer is rising. That's a good thing. We want to catch these cancers early in their course. The goals of surgery, if they are amenable to surgery and operable, are to achieve complete resection. That's vital to avoid recurrence and long-term survival for these patients, to obtain negative margins, no cancer at the edges of what we're removing, to obtain adequate staging at the time of the operation, to identify additional tumors that we may not have otherwise recognized on preoperative scans, and to perform an adequate lymphadenectomy. What does that mean? Removing lymph nodes in the area that may contain cancer so we can appropriately identify the extent of the disease and then offer the appropriate treatment for that patient. And parenchymal sparing operations, trying to preserve lung more and more. If we can, say, instead of removing an entire lobe of a lung, remove a part of it. A lobe is a very large area of lung. It's three lobes on the right, two on the left. If we can remove a segment instead and spare that patient some loss of lung function, that's probably something worth trying to achieve. However, there are several challenges intraoperatively that may not allow us to obtain those goals. Up to 17% of patients may have occult or unrecognized tumors at the time of operation that weren't necessarily seen on the preoperative scans, and these may be early-stage precancerous lesions or early-stage lung carcinomas outright. Up to 15% of the time, especially in an era of increased minimally invasive operations, robotics, etc., where we may not be able to get our hands into the chest, feel the tumors, one of the classic and traditional ways of identifying tumors, it may be very hard to localize a small primary tumor, to know where it is in the chest if we can't see it visually or manually. And then to assess the margins, to obtain that negative margin. There's an 8% or so positive margin rate that's identified after the operation's over, after you have left the OR and the tumor is assessed by the pathology team and comes back a week later. So there's no opportunity there for intervention for that positive margin when it could have been corrected potentially in the operating room. Intraoperative molecular imaging is a technology that uses a tracer, some sort of molecule that binds to tumor cells or whatever tissue you've designed it to bind to, a linker, and then a dye. The dye is a fluorescent molecule. It's excited by laser. It emits fluorescence. To put it simply, these are molecules that make tumors glow when you have the right camera system to visualize them. OTL-38 is a novel molecular imaging agent, a first of its kind, that uses the folate receptor alpha tracer. That's important. That's the molecule that's expressed very highly on certain types of lung cancers. A linker, and then a dye that fluoresces. Again, using the appropriate camera system, you create fluorescence with this. Again, making specific types of lung cancers glow. It is given intravenously as an IV, meaning a systemic infusion, as opposed to some other types of ways that we localize tumors by injecting them directly with more invasive means. So it's quite easy on the patient in that sense. It is specific to a type of cancer called lung adenocarcinoma, and it's the first of its kind, and then it has that specificity and goes right to that tumor, has very high binding affinity, and is stable in its binding. and it requires a dedicated near-infrared camera system in order to visualize it. Near-infrared is the spectrum of light that these cameras see in. The very simple question that this trial asks is, can intraoperative molecular imaging with OTL-38 improve the quality of lung cancer operations? It was designed as a multi-center trial with almost all the sites in the US and one international site. It was approved by the IRB at all the individual institutions, and the enrollment criteria were quite simple. You needed a high-quality CT scan within 6 weeks of the operation, what we call 1 millimeter cuts. That's the thickness that that CAT scan sees through. It's a very thin slice so that you'd hope we wouldn't miss any significant lesions or tumors that might be in that lung. A pulmonary nodule or tumor of some type has to be identified in that patient, and the patient had to be scheduled for curative resection. The endpoint of the trial was to look for what we call clinically significant events. What's that? That is a case in which the imaging technology only was able to identify either a new occult or unrecognized tumor in the lung that was not seen on the preoperative imaging or recognized by the surgeon, localize the primary tumor that couldn't otherwise be localized by the usual means, feeling or seeing, and identification of a positive margin in the operating room with the molecular imaging system and not with just the surgeon's routine assessment or frozen section that we use. So again, these are important. The clinically significant events that are the endpoints are those events that the imaging system changed the course of the operation. The dose is not so important here, but the drug is given 2 to 6 hours prior to surgery, intravenously, again, not directly injected into the tumor or otherwise. This is a systemic drug, goes throughout the body and then hones in on the cancer or the tumor or the tissue that it's designed to go to of interest, in this case, lung adenocarcinoma. There are 3 phases then to the study that the surgeon performs. Lung inspection. The surgeon first, using standard of care, visual inspection, palpation, is going to try to identify, for the purpose of this trial, any additional lesions. Lesions, a generic term we say for tumor or some finding in the lung that we didn't suspect earlier. Tumor resection, finding the primary tumor that we know about from the CAT scan, the one we went there to get, and removing it appropriately with the appropriate operation. And then the specimen check. Once that specimen is removed, right there in the operating room, while the patient's still under anesthesia, still within the operation, taking a little time with the molecular imaging system and standard of care to just inspect the tumor, and I'll show you a little bit about that to see if there's a positive margin. The data points are as listed here, and we'll go through some of these endpoints. So what does it look like? A picture really is worth 1,000 words here. On the left of the screen, you're going to see the white light imaging, routine camera that we'd use. All these cameras have the capability of using just standard white light imaging. On the right is the superimposed imaging from the molecular imaging system, the glow that you see there. This patient was infused with the drug 6 hours before surgery, 2 to 6 hours, and you can see on the white light image, there's nothing there. You can't see that tumor. But on the molecular imaging, it is quite clear and observable. This is an additional adenocarcinoma, lung cancer, that was identified and confirmed by pathology after the operation and would not have been found without the molecular imaging technology. Another example, again, not much observable on the side with the white light, the natural light, but very clearly and starkly contrasted using the contrast imaging agent. So the visual, I think, intuition here is it's powerful in its ability to clearly identify potentially findings you would not have otherwise seen or recognized, and certainly the opportunity then to remove them for that patient. This is margin assessment. What you see here is a staple line. We use surgical staplers to remove many of these tumors. The tumor is quite close to that staple line. This is important. It's a vital component of lung cancer surgery to completely remove the tumor. If we don't think we can do that, you may not offer that patient the operation. The image with the white light, it's not quite clear to the surgeon. What part of that is tumor? Is it near the staple line? The molecular imaging is very clear. The glow clearly overlaps the staple line. This is a positive margin. This was confirmed as a positive margin on the postoperative pathology assessment by routine staining of that tumor. In contradistinction, here's a tumor that is clearly within the substance of the lung and well away from that staple line. You see the white light imaging, Where's the tumor? You can't see it. You see it very clearly on the molecular imaging, and now you can be quite confident that this is a negative margin. And this is exactly how it was used in this study. For the purposes of this study, any tumor that was within 5 millimeters of that staple line was considered a positive margin. All of these specimens were verified by the pathologist, not only for the type of tumor that it might be. These are routine pathology stains that every specimen undergoes, but also a special stain to look specifically at the folate receptor to make sure these tumors were expressing the folate receptor. That's the receptor on these tumors that molecule is targeting specifically. 110 patients were enrolled, and after exclusions, 92 patients ultimately were analyzed. The mean age was 67 years. There were more female than men. About 50% or so had a preoperative diagnosis. For the other 50%, that diagnosis was made at the time of surgery. And in some cases, the fact that the tumor even took up the dye highly suggested that these were adenocarcinomas. Remember, this is now the first dye of its kind that is specific to adenocarcinoma of the lung. So it's a paradigm shift in that we can now start talking about visual biopsy. We are understanding that this is a tumor just based on the fact that it glows. The mean preoperative tumor size was 2.3 centimeters by CT scan. It appears to be a very safe drug. It had most commonly nausea and some hypersensitivity reactions that were treated with basically Benadryl at the time of the infusion. What we call grade 1 and 2 toxicities, very low-grade toxicities. There were 2 grade 3 toxicities, which now get into the higher realm of toxicities. 1 chest pain patient during the infusion with a normal EKG and negative troponins. That's the test that we use to if there's any heart strain. So that was not due to any compromised heart strain. The other patient had transient O2 desaturation, meaning they needed some oxygen put on during the infusion. Both of these things stopped completely once the infusion was stopped. Both of these patients went on to the trial. And no long-term sequelae past the infusion time. There were no imaging-related events due to the use of these proprietary cameras. 64 patients underwent a wedge or relatively limited resection of the lung, 16 a segmentectomy. We talked a bit about that segmental resection, which is a little bit more than the wedge, maybe what we call an anatomic resection. That may more appropriately remove lymph nodes and be a better cancer operation. 43 lobectomies, the real gold standard operation for most lung cancers, and then a handful of other more rare types of cases and more extensive surgery. 64 of these were adenocarcinomas of the lung. Here's a gross overview of the clinically significant events. We'll go into more detail in just a minute. But again, these are the clinically significant events that occurred because the molecular imaging technology identified it beyond what our standard of care could not do. The imaging technology identified 9 synchronous nodules that would not have otherwise not have been found, 9 additional lesions, cancers in those patients. Localized the primary tumor, identified 11 of them that would not or could not be found by standard inspection, and found 9 positive margins that would not have otherwise been recognized at the time of surgery. In total, there were 29 CSEs, clinically significant events, in 24 patients. So approximately 1 in 4 patients benefited from the technology in one way or another by having a clinically significant event that altered the course of the operation for that patient. Looking a little deeper into this data, it's a bit of a busy slide that I will guide you through. There were 24 nodules in 7 different patients. That's 8% of the patients identified by the molecular imaging that were identified by that imaging alone. 9 of those additional nodules were in fact cancer, some of them early stage lung cancer, so potential that that patient was now cured because that cancer can be found, and surgical resection is the gold standard. 1 metastatic non-small cell lung cancer and 2 metastatic thyroid tumors that were found in the lung by chance that would otherwise not have been seen. Now there were 16 false positives. It's not a perfect technology. It will pick up other nodules that may not be cancer because of the way that the dye can be taken up by certain other types of cells called macrophages or leak into tumors. Inflammation is one other area where it may pick up. AAH, written here, is adenomatous alveolar hyperplasia. It's considered a precancerous lesion. It's not quite cancer yet, but it's potentially going to get there. We did not include that in the study endpoints as a positive finding, but it is a precancerous lesion. And granulomas were the other sort of finding that were false positive. Granulomas are inflammatory, non-cancerous lesions, so they are one confounding factor. 8% of patients, importantly, were upstaged, or their staging, cancer staging changed because of the molecular imaging, which now gives the physicians the opportunity to better understand their prognosis and to better offer additional appropriate therapy. If you have an early stage patient who's not appropriately upstaged to a stage 2, you lose the opportunity to give that patient adjuvant chemotherapy, a very important part of the treatment for stage 2 lung cancer. And if you can't stage that patient appropriately, you will affect their survival if they do not get that treatment. Tumor localization, 13 patients did not have tumors that were localized by standard of care. 11 of those 13 nodules in those patients, 11 of the 13 patients, the molecular imaging did go on to find the nodules that could not be found by standard of care. 2 that could not be identified were very deep nodules within the lung that required a lobectomy to remove. And 6 of the 11 were what we call GGOs, ground glass opacities. These are true cancers, but they are indolent. They are very slow growing over time. They light up well. The standard of care is to treat them still as lung cancer. Certainly if you find them at the time of an operation, the general consensus is to remove them. This particular technology may be very good for finding these ground glass opacities, which can be very difficult to find. They are not quite as solid. They are semi-solid lesions and can be on the smaller side. Margin assessment, 16 close margins, less than 5 millimeter, were identified by this technology. 9 of those 16, or about 50%, were positive on final pathology, meaning on the post-operative assessment. And 9 margins, or 9% of patients, that close margin was identified by the technology alone in the operating room. Would have been missed if that patient had left the operating room without the molecular imaging technology. And therefore, the opportunity to correct that positive margin lost at the time of surgery. So in total, again, 26% of patients in one way, shape, or form using these 3 clinically significant events benefited from the operation. In conclusion, intraoperative molecular imaging with OTL-38 can potentially improve quality of lung cancer resections in approximately 24% of patients, about 1 in 4 patients, through improving identification of occult meaning unrecognized tumors at the time of surgery, facilitating the localization of primary tumors. Where are they in the lung? If you can't find them by routine means. If you can't find them, you can't remove them, at least not appropriately. And improving real-time intraoperative margins. Therefore, IMI with OTL-38 has the potential to improve recurrence and survival outcomes for these patients. There is a future phase 3 multi-institutional randomized trial that is currently in planning and preparation for, I think, launch in the near future. Thank you very much. I think it's very important to realize I am here privileged to present on behalf of the co-investigators. This is largely the work of Dr. Singhal from the University of Pennsylvania, who has done a lot of work in this field. And I think we have all been very privileged to be part of this study. Thank you very much.
Very good, thank you. The discussant is Dr. Linda Martin from the University of Virginia at Charlottesville.
Good afternoon. Thank you for the opportunity to discuss this very important work. As we progress in lung cancer, there have been many really important breakthroughs in lung cancer in the last few years. Probably one of the most impactful of our time is lung cancer screening, which was published in the National Lung Screening Trial in 2011. It's been a bit slow to be adopted. It took about 4 years to get approved by insurance, but we're gradually starting to see more lung screening be invoked. And with lung screening, fortunately, we're starting to catch more and more small lung cancers or even nodules that we're not quite sure what to do with them. Historically, if patients were diagnosed by traditional means, they were stage 4 over 60% of the time. So as we move into this earlier detection, we have to up our game as to how we're going to address those small nodules and how we're going to find them. At the same time, advances in lung cancer involve more minimally invasive surgical approaches, and the two together sort of work in opposite directions. The smaller nodules are much harder to find with minimally invasive approaches. So it begs the question of what can we do to get better at finding those small nodules in a way that's easy on the patient. And the techniques we've used in the past have been techniques that need an additional procedure, sometimes the day before, sometimes the day of. It's putting the patient through more things, it's cost, and they're not always that helpful or accurate. We've done things with navigational bronchoscopy where we inject a dye, or going to interventional radiology to have a wire placed like we do for breast cancer, or injecting a nuclear tracer dye, and those all have limitations. They all involve some risk and additional procedures. And this approach has the great appeal of simply an intravenous infusion that can be given to the patient as they're getting checked in for their preoperative preparation. Very, very minimal risk of adverse effects just from the agent that's given intravenously, but there's no invasive procedure. There's really minimal effect on the patient. When we get to the operating room, we now have this technique that just with a special light, we can see where the tumor is. And it helps us find the tumor of interest, but it also is showing that we're finding other lesions and that those lesions are there about 8 to 15% of the time. And we just weren't very good at finding them. We didn't have a way to find them. And then that effect of assessing the margin, knowing right then and there, did I get it all? That's what we want to know. That's what patients want to know. And those things are really invaluable for pushing the field forward. And so this is really great technology to help us keep up with the times with the new lung cancer screening and the identification of multiple small nodules. And in fact, I think the ground glass opacity, Dr. Sarkaria touched on that. These are these sort of hazy lesions. They're difficult to palpate. So even with open surgery, they can be very difficult to find. It's kind of like just a thickening, maybe. You may or may not be able to feel it. But they very much can harbor an adenocarcinoma, and we struggle with how best to localize this. And it turns out that this folate alpha receptor is highly expressed in these ground glass lesions, and so that's an advantage that nothing else has been able to report prior to this.
Very good. Questions?
Lynn Peterson from Trends in Medicine. So for people who have contrast allergies, can't take contrast agents for CT, can they have this?
That's a great question. So this is not at all related to intravenous contrast for CT imaging or anything like that. This is a completely different agent. And another point is that there's no radiation involved with this, whereas a lot of the other techniques we've used before that I just mentioned do involve ionizing radiation, and this doesn't involve radiation. Someone asked if you're pregnant and you're an anesthesiologist in the OR, do you have to step out? No, it's nothing to do with that.
And follow-up.
Yes.
So is this compatible? Just one. Okay. Is this compatible with both Ion and Oris, Monarch?
I'm sorry, I'm not sure.
Can you use this with the with Intuitive's Ion or J&J's Monarch?
There's, I think, 5 different camera systems that will allow for detection. I don't think there's any proprietary interest yet as to if there's a preferred camera or not. The robotic platform, the intuitive robotic platform, is not specifically, the Firefly is not specifically set up for this, so it takes a different type of infrared light source to detect the dye. It's not the dye, the tracer.
So the Ion and Oris, there's not quite a bridge or connect here between these two technologies. You're talking about really robotic bronchoscopy, which would be more applicable to, say, if you were going to inject or biopsy at the time. We are not biopsying these. We're talking about marking these molecularly with a tumor glow or a glowing type of fluorescent agent, and then going to surgery in order to remove them. Are there opportunities here for robotic bronchoscopy? Potentially, but you're really speaking more about an invasive procedure. So just to sort of redirect that question, there's probably not much intersection right now between these two technologies.
Yeah, Stephen Greenhouse from Cardiovascular News. I go to a lot of conferences where it's not surgeons, and one of them is interventional radiologists that have this new area called interventional oncology. And what you're describing is the use of imaging to get kind of more accurate and smaller surgery. But they would argue that they kind of do interventions and use image-guided therapy to do the same. I'm wondering, do you see that this is an area where interventional techniques could be used and benefit from this imaging?
Potentially. This, again, we're talking really about two separate fields that are converging on the same disease process.
It's the same disease.
Absolutely. So which way is the field going to go? Interventional techniques, which may be ablation, sclerosing, it may be injectables of chemotherapeutics directly into the tumor, radiation, SBRT, stereotactic battery radiation therapy, it may be cryoablation, it may be any number of techniques, microwave ablation. And these are deliverables that are, there's a very exciting field emerging where robotic bronchoscopy, advanced bronchoscopy may be able to deliver these therapeutic techniques to these tumors. Whether this type of technique is going to be necessary for that, potentially. But we're talking about an endoluminal approach with robotic bronchoscopy where tumor glow is probably not going to be of great facility. And the camera systems that have to be utilized in order to perform near-infrared fluorescence imaging will not be, the technology is simply not there to put it through a robotic bronchoscope at this point. These are true dedicated lenses and camera systems built for surgery. Will there be potentially in the future? Of course, as technology goes forward, I don't see why, but right now I don't see a terrific intersection between these two areas. The question is really asking, which way is the field of lung cancer treatment going for early stage lung cancer? And you're absolutely correct that we have to pay very close attention to these emerging techniques, whether it be robotic bronchoscopy or other ablative techniques for lung cancer that can avoid surgery altogether. Absolutely.
Thank you.
Any other questions? 75% women. Is that because it's adenocarcinoma? Is that because lung cancer is becoming more prevalent in women than men? And is there any evidence that there's any difference in the way this technology works in women versus men?
There is a higher rate of adenocarcinoma in women, so I would suspect that is the rationale. It doesn't seem to be any hormonal effect. I guess that's maybe a more direct way of answering this. But I think we're probably just seeing the epidemiology of the disease, that there's more adenocarcinoma in women. As far as the relative incidence and increases or decreases by gender, way beyond the scope of this particular trial. But
we also know that for adenocarcinoma, especially non-smoker women, epidermal growth factor receptor positive, this is a type of marker that is seen more in non-smoking women. So it's not unusual in adenocarcinoma, especially now that we're identifying more early stage, to identify this specific subset of tumors, initially called bronchoalveolar carcinomas in the past, but really the same type of minimally invasive adenocarcinoma, not quite as aggressive as a traditional adenocarcinoma, but a true cancer nonetheless, and an invasive cancer.
So you indicated there's without this, there's an 8% margin, positive margins. Is that overall from this group? Is that your hospital?
No, that is background information. That is from the literature. The literature suggests an 8% positive
At your
margin.
hospital, what is it?
I do not know what it is at my hospital or at any of the individual institutions. I would suggest that that's in the range, but I would have to go perform an audit of my hospital's pathology in order to really identify that number. We didn't identify that necessarily here for the purposes of this study either. But I can certainly look that for you and verify
Well, the reason I ask is that at the breast cancer meeting last month, I actually was looking at this issue. And at MD Anderson, it's 2%. At somebody else I talked to, it's 3%, but nationally, it can be as high as 70%. And so I'm wondering if part of these results are skewed because whoever's doing it, their rates, because 8% is either a little high or maybe low.
Depends on the nature of the disease. To me, it sounds about right on par. and knowing from our STS data what's our margin positivity, I would have to go back and review it for you and then get back to you on that question specifically. The main idea here, though, is regardless of what that rate may be, if we can identify that positive margin in the operating room before leaving, that's the real paradigm shift. We don't have a great way to do that right now other than frozen section. Frozen section requires you to cut the tumor in a certain way to alter the characteristic of the actual tissue, and may still come back with an answer that's different after the operation. You may think you have a negative margin, the final pathology may come back as positive. If you have an opportunity in the operating room to change the course of your operation because you now have a technology that allows you to identify that positive margin, even though the number of what your institution may have as a positive margin rate is important to understand, this will almost certainly reduce that rate. That's the key concept for this particular technology when it comes to margin assessment. And if you can then, with more confidence, remove the entire tumor, it naturally follows that recurrence rate and survival, which is vitally important on complete resection of tumors, should improve. We don't know that yet. This study was not designed to look at long-term survival. That was what future trials will look at.
Other questions? Very good. Thank you very much.